bone on bone. Their physician has recommended their joint be replaced, a total knee arthroplasty or TKA. It sounds like a conclusion, like the conversation is ended and surgery is the only remaining path forward. But the phase bone on bone should not be a shortcut that bypasses this conversation about what else might be possible. Because for a meaningful percentage of patients, that conversation changes everything. I'm Dr. Tammy Penhollow. I'm a physician specializing in regenerative spine and joint care. Joint space narrowing, which is what bone on bone of the knee refers to, is on the imaging where the cartilage cushion between the femur and the tibia has thinned significantly, in severe cases to the point where the bones appear to be in contact on an x-ray. It is a structural finding. It tells you something about what the joint looks like at that moment in time. What it does not tell you is whether the right conditions for a regenerative approach still exist. And that is a separate question. There is a 15-year randomized controlled trial, 140 patients, all with bilateral grade 4, the most advanced, knee osteoarthritis, meaning significant bone-on-bone disease in both knees. One knee received a total knee replacement. The other knee received subchondral bone marrow aspirate concentrate, BMAC therapy. The same patient with the same disease severity in both knees. At 15 years, approximately 80 to 82% of the BMAC treated knees had not required a total knee replacement. The 18 to 20% who did eventually need one waited a mean of 10 years before that became necessary. The route of administration in this study was subchondral, meaning into the bone itself, not just into the joint. That distinction is clinically important, and most patients never hear it. Intra-articular injection, meaning into the joint space, is the more common approach. But in Hernigou's data, 70% of patients who received only intra-articular injections went on to require a total knee replacement over the same follow-up period. The subchondral approach targets what is called the bone marrow lesions. Bone marrow lesions can exist on the inside of the joint, the outside of the joint, or in the case of patellofemoral osteoarthritis, within the patella or kneecap itself. They are visible on MRI. Not on x-ray. They are a driver of pain and joint deterioration, and they're the actual target when I inject into the subchondral injection. When you inject and treat the subchondral bone rather than just the joint space, you're addressing a different and more foundational layer of the disease. No infections and no adverse outcomes were reported in the BMAC-treated knees across 15 years. This is not a trivial point. Total knee arthroplasty carries known surgical risks, including infection, blood clot, and the need for revision surgery over time. The revision rate for TKA follows a very predictable curve as implants age. The BMAC-treated knees in this study did not carry those risks. Not everyone is a candidate for this approach, and knowing who's not a candidate is equally important. If you have an ACL tear, a PCL injury, or significant meniscus damage creating an unstable joint environment where your knee is locking, you are losing balance, you are catching yourself from falling all the time, I'll refer you for surgery. A biologic therapy cannot stabilize a mechanically unstable joint. Trying to do so wastes the therapy and the patient's time and resources. The right candidate has degenerative osteoarthritis, identifiable bone marrow lesions on MRI, adequate disc height in the case of spinal involvement, no structural instability requiring surgical correction. When those conditions are met, the conversation about candidacy is worth having. If you are not local and cannot travel to Scottsdale, I offer a 5-session intensive done entirely over video where we work through your specific situation one-on-one in real time. The window for candidacy is not permanent, and waiting has a biological cost. Bone marrow lesions progress. Joint space continues to narrow. The inflammatory environment inside the joint compounds over time. There are parameters that determine whether someone is still within that window for a regenerative approach to have meaningful biology to work with. When someone spends a year or two in the wait and see phase or cycles through treatments that do not address what's actually happening, that time has a cost in terms of what remains available as an option. The Hernigou data was not collected on patients who waited until they had no other choice. These were patients who still had a bit of joint space remaining. They were under a certain centimeter size and a biologic environment capable of responding to treatment. The window exists, but it does not stay open indefinitely. A comprehensive protocol goes well beyond the injection itself. My protocol for BMAC therapy involves intraosseous injection to address the bone marrow lesions, combined with platelet-rich plasma delivered intra-articularly to address the joint environment, along with treatment of all relevant soft tissue structures. But the injection is not where the preparation begins. Before any biologic procedure, I want the patient's metabolic environment optimized. That means nutrition, laboratory work, inflammatory markers, metabolic factors that influence how the biology responds to ensure that the joint is not being loaded in ways that undermine the therapy. It means identifying and correcting the factors that have been feeding the deterioration. The biology works better in a prepared environment, and the preparation is part of the protocol, not a separate conversation. When someone knows this data exists, they do not just accept bone on bone means knee replacement as the complete answer. They ask whether they're a candidate for something else. They ask what their bone marrow lesions look like on MRI and where they're located. They ask what the biological environment of their joint currently supports. And they lead to different conversations, sometimes different outcomes. But you can't ask a question you do not know how to ask. Surgery, when it is the right answer, is not the enemy. But it shouldn't be the default when there's evidence for an alternative. I refer patients for surgery. I believe in surgery for the right indications. ACL reconstruction, meniscus repair in the right patients, total knee arthroplasty when the joint has reached a point where there are no other options. These are not failures. There is 15 years of randomized data showing that for appropriately selected patients, a subchondral regenerative approach can delay or replace total knee replacement with no infections, no adverse outcomes, and an 80 to 82% rate of avoiding replacement surgery across that time frame. If you're sitting with a bone-on-bone diagnosis and a surgical recommendation, the most important thing you can do before making that decision is ask whether you've been evaluated for candidacy for something else. Not because surgery is wrong, but because your decision deserves the full picture. Keep learning. This is always a good next step.